Good evening, sir.
Good evening. Start?
Yes, sir. Audible.
Yeah. Can you?
Good evening, respected professor, and I welcome all our dear students for one more session of Raisa DNB academic activities. Today we have IV fluids and drugs in anesthesia. Without wasting much of time, I hand over the session to professor. Thank you, sir.
Class start பண்றேன் போகட்டுமா அப்புறமா
Sir.
Hi. Yeah. So visible? The screen visible?
Visible, sir.
Am I audible?
Yes, sir. Audible, sir. Yes, sir.
Okay. I think any idea up to what slide we covered last time? Did we cover adenosine dopamine? Any of the students who remember? I think we completed sympathomimetics, isn't it? Dopamine, Anticholinesterase, and all those I think we completed last class. Did we talk about adrenaline last class? It's a very important drug. Hello?
I request all the students to unmute themselves and they can answer whenever sir is asking any question.
Am I audible to the machine?
Yes, sir. Audible, sir.
Okay, okay. So
Students, sir is audible for all of you. You can either type in the chat box or you can unmute yourself and answer.
Audio is too low, sir. Audio sound is very low, sir.
what now? Is it better?
And now it is same, sir.
Yeah, only, yeah.
Dr. Pratik,
I'll check
Shukla,
whether it's my problem. I'll disconnect and join back, sir.
Your voice is quite audible now.
Yes, sir. I am able to hear you clearly, sir. Your voice is very clear, sir. Audible, sir.
Pratik, what are the exam going pages in the audience? Arun, are you there? Am I audible to you?
Yes, sir. Very clear. Dr. Sahu, sir is audible clearly?
Yes, audible.
Okay,
Thank you.
Yes, audible. Sir is audible.
right. Okay. What about exam going pages? So some of you can unmute and start answering. What is shown here? So one of the important drugs which can be kept in the exam. As I told in the earlier class, it's like a mock viva for you. So another 2 weeks to go for the exam. I think you should try answering and attempting these questions. What is shown here? You can answer. No one wants to answer? When do you use
Students, I request you all to unmute yourself and answer, or you can type in the chat box.
That box won't be visible to me.
Adrenaline.
Adrenaline, somebody is answering. I'm able to faintly hear.
Sir, yeah, phone.
What is the difference between these two preparations? Was it asked in the last class?
One is bitartrate preparation and other is hydrochloride preparation.
Yeah, that's you can read it and immediately see that. But what is the main difference? Why the preparation of these two salts? What is the main difference? Bitartrate, it's synthetic. Okay. Whereas hydrochloride is an extraction from bovine adrenal gland. It's more or less a not natural extract. Okay. So nowadays you don't get much of hydrochloride salts. You get mostly bitartrate. Previously we used to get both the preparations, adrenal hydrochloride and adrenal bitartrate. Okay. What are the uses of this drug? The difference.
Adrenaline is used in the management of cardiac arrest.
Ah,
It is used in the management of anaphylactic shock. It is used in the treatment of refractory hypotension.
yes. So, cardiac arrest 1 to 2 milligram every 2 to 3 minutes for adults and 10 mics per kg for pediatric. And another important use is anaphylaxis. That first drug of choice is adrenaline. Don't say antihistamine, steroids, all these things in the examination. First answer for anaphylaxis, you should always say it is adrenaline, but not in the dose that what you give for cardiac arrest. It is only small doses like 100 mics IV or maximum IM you can go 0.3 to 0.5. Okay, this is the answer for anaphylaxis, and that's an inotrope in ICU, starting from 0.01 mics to 0.3 mics per kg per minute. What are the actions of adrenaline on the heart or the cardiovascular system? Is it a mainly beta receptor agonist or does it have alpha receptor action also?
It has
That's
both
on all
alpha and beta
receptors.
action.
Mainly a beta receptor, but with high doses it can produce alpha receptor action also. Primarily it is beta receptor, whereas noradrenaline is primarily an alpha receptor agonist. So you will have more of vasoconstriction and increase in blood pressure. What is the use of noradrenaline? Where do you use noradrenaline preferably? The main indication for use of noradrenaline.
It is used in septic shock.
Yeah, septic
So it
shock.
is-
Electric shock.
Yes, mainly septic shock or vasopressoric shock. What is supposing cardiopulmonary vasopressoric shock when noradrenaline is not effective? What is the other alternative?
Vasopressin.
Huh?
Vasopressin.
Vasopressin. Or vasopressoric shock following cardiopulmonary bypass.
Adrenaline should be used.
Huh?
Adrenaline.
No. Vasoplegia means vascular compartment is paralyzed. It is dilated. It's not contracted. You have tried noradrenaline as a primary because it's a primary vasoconstrictor. Okay. So you are trying that, it is not working. What is the next alternative? Methylene blue. Okay. So vasoplegia following cardiopulmonary bypass, non-responsive to noradrenaline. The next step of choice is methylene blue. Okay. Then it's nebulized in asthma. You can use. You can add it to LA drugs to prolong the action. So remember those 5 answers. Now this is noradrenaline, which is also a common drug which can be kept in the exam. What is the salt? You could find it here.
Bitartrate.
It's bitartrate. Very good. So it is, even though it is sterile noradrenaline concentrate, that is the name given, this is also a bitartrate. What type of infusion set to be used for any inotrope administration?
Micro drip sets.
You go for drops per minute, which is a micro drip. I think all these things we discussed in the last class. So I press through that. Then dopamine and dobutamine. These are other two common drugs which will be asked in the examination and which you are also familiar in your day-to-day practice also. So dopamine, most of you would have had the chance to use in your training period. Okay. So it is a natural catecholamine. It's a precursor. So whenever they talk about adrenaline, noradrenaline, dopamine, they can ask you about the synthesis of these catecholamines. What is the primary substrate from which catecholamines are synthesized?
Tyrosine.
Tyrosine. Before tyrosine?
Phenylalanine.
Phenylalanine. Yes, that is the basic primary substrate. Okay, phenylalanine is converted to tyrosine. That is why when you say dopamine, what is the dopa? What is the expansion of dopa? Dihydroxyphenylalanine.
Alanine, yes, sir.
Okay, so that is the base substrate. So you must start from phenylalanine and not from tyrosine. So phenylalanine is converted to tyrosine. Tyrosine is converted to dopa. Dopa is converted to dopamine. Dopamine is converted to noradrenaline. Noradrenaline is converted to adrenaline, which is produced in more quantity in the body, adrenaline or noradrenaline.
Adrenaline, sir.
Adrenaline, why so much of hesitation? It is always the final product which will be produced more. Similarly, if you take T3 and T4, which is produced more?
T4, sir.
T4. Even though the active substance is T3, T4 is produced in more quantity. Okay. Similarly, adrenaline is produced in more quantity, even though noradrenaline is the main neurotransmitter. Okay. So remember always, adrenaline is produced more in quantity. That is, this steps also you should remember. And what are all the various effects that are given here. And how these drugs are marketed, they can be marketed as a vial, or it can be marketed as a powder or ampules. So many forms it is available. Okay, these things you must be familiar with. Now coming to digoxin, did we discuss this in the last class? Ago? Yes, I think we discussed it. This only I think I stopped. So 500 microgram to 2 ml. That is the normal injectable preparation. Is digoxin available in any other form?
Tablet form.
Yeah, tablet form. It's commonly used in yesteryears by the physicians for treating
Heart failure.
heart failure, mainly which heart failure produced by which particular pathology?
Weekly, it is
Mitral valvular diseases. Okay, in those days with mitral valvular diseases where there is a ventricular dysfunction, they used to treat that with digoxin, both for rate control as well as increasing the contractility. Okay. So it is available as tablets as well as injection. When will you use the injection? When will you use the tablet?
When fast digitalization is required, then injection is used.
So orally, when you want a slow digitalization, you can go for oral tablet. When you want rapid digitalization, you have to go for injection. Okay. The mechanism of action, it has two actions. One, it is acting on the sodium ATPase pump, blocks that. Then it allows the more sodium to be retained in, increases the intracellular sodium level, and there is a clearly gradient produced between the calcium and sodium. So sodium will be exchanged for calcium. So intracellular calcium will increase, and this will bind to the troponin C and increase the inotropes. Okay. So the whole mechanism starts from the action of the sodium ATPase pump. By blocking it, it is allowing sodium to be retained inside. That is the first step. When the intracellular concentration of sodium becomes higher, then it gets exchanged through the sodium calcium exchanger, allowing more calcium to come in and allowing sodium to go out. So the increase in intracellular calcium causes increased binding with troponin C, then causes the inotropes. So that is the whole mechanism of action of digoxin. It also causes increase in vagal activity, and that is how it is able to reduce the rate. Okay. So the force of contraction is improved by this calcium accumulation, and rate control is achieved by stimulating the vagus. This is another drug which can be commonly kept in the exam. It's isoprenaline. So what is isoprenaline? What is the definition of that? Beta receptor agonist, non-selective beta receptor agonist. That is isoprenaline, analog of epinephrine. It is a synthetic analog of epinephrine, and it causes more of increase in the heart rate. So whenever there is a bradycardia unresponsive to atropine, you have to go for isoprenaline. Okay. What are the indications and contraindications? The treatment of bradycardia due to excess dose of beta blocker or heart block, or rarely for asthma also it is used because it produces bronchodilation. It should not be used in people with tachyarrhythmias or tachycardia or heart block caused by digitalis or ventricular arrhythmias. It may cause angina also. What is the half-life of isoprenaline? Very short acting. It's about 2 minutes. Very slow, short acting. What is the dose? These are all kept in the exam. We don't use them in day-to-day practice, so easy remember. But dilute 1 ml, which is 0.2 milligram, 2 milligram. 9 ml, make it 0.2 milligram, and use 0.02 to 0.06. Can be given as a bolus as well as an infusion. So another drug is dopexamine. Dopidac, the synthetic analog of dopamine. Just like isoprenaline is synthetic analog of adrenaline, dopexamine is a synthetic analog of dopamine. So it is presented as 50 milligram in 5 ml ampules. This is the presentation of dopamine. How is dopamine marketed? All of you are using it day in and day out.
200 milligram in 5 ml.
Very good. So this is 250 milligram. Okay. What is the mechanism of action? The beta 2 adenoreceptor and dopamine D1 receptor agonist. No effect on alpha receptor. What are its uses? When will you use dopexamine? Whenever you want more cardiac output, eccentric perfusion, especially in acute myocardial infarction, if the contraction of the heart is not good, you can use dopexamine. What is the dose? 0.5 to 6 microgram per kg per minute. What is the half-life of this drug? It's about 7 minutes. So isoprenaline 2 minutes, dopexamine 7 minutes. All other drugs are all, because most of the drugs are short acting, we are using it as an infusion. So because their half-life is very short, all the drugs which have a very short half-life, we have to give it as a continuous infusion. Otherwise, you won't have a sustained effect. What are the potential hazardous interactions of the other drugs? Antidepressants, it can cause hypertensive crisis, especially with MAO inhibitors and moflobamide. Beta blockers, there is a risk of severe hypertension. Sympathomimetics, effects of adrenaline, noradrenaline, possibly enhance. This is another drug, Adenosine, which is also cardiac related drug. It's marketed as a 2 ml ampule containing 6 milligram. What is the dose? The naturally occurring purine nucleoside. Adenosine, one of the 4 nucleosides, building blocks of DNA and RNA, which are essential for all life. And the difference, what is the difference between a nucleoside and a nucleotide? This also we discussed last class.
One extra ATPase.
Yes, phosphate. Yes. There is no phosphate attached, it is a nucleoside. It is a base with a sugar. If it is there is a phosphate attached to that, the base and sugar and phosphate, it becomes a nucleotide. Okay. Side is 2 sides. Tide is the tide, 3 things there. What are its uses?
Used in supraventricular tachycardias.
Treatment of SVT. It can be used for nuclear stress test also. Due to thallium. What is its mechanism? Mechanism of action is it causes increase in potassium efflux. This increases of potassium decreases calcium efflux, hyperpolarizes the cardiac cells, thereby slowing the heart rate. Okay. So, can be given as a rapid IV injection. After half-life is very, very short, 2 to 10 seconds. But it may cause flushing, chest pain, and dyspnea. And it may also cause bronchial asthma. So it's contraindicated in patients with bronchial asthma. Okay. So half-life is less than 10 seconds and rapidly deaminated in the plasma, taken up by RBCs. These are all the points you have to remember about adenosine. Coming to esmolol, a common drug which may be used several times in your practice. What is esmolol?
The ultra short
Ultra-short-acting beta blocker.
Cardioselective beta blocker. So it's a cardioselective beta blocker. Doesn't have any other action like your parenteral propranolol. It's not the non-specific. It's more cardioselective and specific. What are the uses of this drug? Can we use it?
for control of acute hypertension emergencies. And to attenuate the sympathetic response during the intubation and endoscopy.
Very good. Use blunting the hemodynamic response laryngoscopy intubation can be used in atrial fibrillation but
To control the rate, heart rate.
reduce heart rate and BP during cardiac surgery or beating heart surgery. Terminate supraventricular tachycardia. Why is it named esmolol? What is its relevance to its metabolism?
RBC esterase.
It's a S-molar ester methyl. It's an ester methyl structure. So they have taken this ES and the M from this. So they are also ordered lol. All sotalol, tramitolol, all those lols are all acting on the cardiomyocytes. So that is why that has been added. Okay. Atenolol, teprolol, all those olols are all acting on the cardiomyocytes. Has been taken by them and metabolized chiefly by the esterases in the cytosol of the red blood cells and not by plasma cholinesterase or interplasmic. What is the dose?
0.5 to 1 mg per kg as a bolus.
Very good. 0.5 mg per kg given, followed by infusion rate is 0.05 to 0.2 milligram per kg per minute. If you want to put an hypertensive crisis, that is the infusion dose. But loading dose is always 0.5 milligram bolus for the other conditions. This is another common drug, hydro, is used. What is the main action of amidron? In various strengths, in ampules as well as in vials. 50 milligram in 3 ml, 900 milligram in 18 ml, so many concentrations. But basically, it is 50 milligram per ml. That is the concentration in which you will get. So 50 milligram per ml, what is the percentage? Will you describe?
0.5%.
Not 0.5. 10 milligram is normal is
Percent. 5%.
5%.
5%.
5%, not 0.5. 0.5 means it's only
5
5
milligram.
5 milligram. The bupivacaine is 0.5%. You have 5
Yeah.
milligram. This is 5%. Okay. So amiodarone. What is amiodarone? Is a
Class 3
benzophenone derivative.
antiarrhythmic.
The action is some antiarrhythmic. But amiodarone is a benzofurone derivative. Chemically, it's a derivative. What is the mechanism of action? How does it act?
Channel blocker. It's a broad spectrum antiarrhythmic.
Blocks potassium channels as well as sodium and calcium channels also. See, basically how the antiarrhythmic drugs have to have only 4 methods of action. One, they can block the sodium, they can be blocking the beta stimulation, they can block the calcium, they can block the potassium. Okay, these are the 4 methods of by which any antiarrhythmic drug can act. And all the sodium channel blocking drugs are classified into class 1A, B, 1B, and 1C. Okay. So this amiodarone will come under both the calcium and potassium channel blocker. So it's a multi channel drug comes into all the categories. Even though mainly it is the potassium channel blocker. But it also has some effect on the sodium and calcium channels and also on the beta receptors so that it can reduce the rate. What are its uses? That is why it is useful both in ventricular and atrial arrhythmias. Can be used both to treat the SVT, ventricular tachycardia, and WPWC. The dose?
5 mg per kg.
5 mg.
What is the bolus and what is the infusion rate? So the loading dose
5 mg per kg is the bolus, followed by 1 mg per minute for the first 16 hours and 0.5 mg per minute for next 8 hours.
So, 15 milligram per kg. What are the side effects? There are a lot of side effects of this drug. Which are all the most important side effects?
Hypothyroid.
Hypotension due to histamine release.
Hypotension is not that much common, but lung fibrosis.
It's an hypothyroid lung fibrosis.
Can cause alteration in thyroid function, both hypo and hyper, photosensitivity, peripheral neuropathy, liver damage, cardiac depression, corneal microdeposits. So you can remember T, 2P, 2L, 2C. T for thyroid, P for peripheral fibers and photosensitivity, L for lung and liver, C for cardiac and cornea. So 7 side effects. Okay. The 3 7. P, 2P, 2L, 2L, 2C. These are all the side effects of the now nitroglycerin, another one which is commonly used, is also available as an infusion for 5 milligram tablets. What's the mechanism of action? How does it act?
Vasodilators.
Cyclic
Nitric oxide, nitroglycerin is converted to nitric oxide, activation of coronary soluble guanylate cyclase, increase coronary cyclic GMP levels, plasmaluminal big channel activation, then hyperpolarization, decrease calcium influx, decrease cytoplasmic calcium, and relaxation of the smooth muscles of the muscular compartment. Okay. Basic thing, first it gets converted to nitric oxide. Nitroglycerin gets converted. Both your nitroglycerin and sodium nitroxide, they basically first form nitric oxide. Then that goes on to this chain of reactions. So ultimately, whenever there is increased calcium inside any muscle, muscle will contract. If there is less calcium inside the muscle, muscle will relax. If you remember this basic point, it is very easy to answer the examination. Increased level of calcium, it will promote binding to the troponin C. C stands for calcium. So whenever you have more calcium, troponin C will be activated, muscle will contract. Whenever you have less calcium, troponin C cannot be stimulated, muscle cannot contract. Okay. Basic, very simple way to remember that. So So stimulation of sarcoplasmic reticulum, calcium ATPase pump, enhance extrareticulum stimulation, reflected as decreased release from, so it will not allow calcium to come outside and also not allow calcium from, because calcium has got two sources. It can enter from outside because it's predominantly an extracellular ion. And it will also be released from the sarcoplasmic reticulum of any muscle cell, any muscle fiber. So you have to prevent both accumulation. So that is the main thing that is done here by this drug, and that is how finally you get the relaxation, not only coronary but also other vessels. Mainly it is an arteriolar dilator or a venodilator.
Venodilator.
NKG is a venodilator, whereas SNP is a arteriolar, predominantly arteriolar dilator. So the effect on the CVS, mainly a venodilator, causes reduction in preload, decreases wall tension and oxygen demand, increases coronary blood flow. That is why it is considered very useful in skin and heart disease patient. The cause of tolerance to nitrates. Nitrates lose their potency very soon when the person starts using it repeatedly. So the tolerance incidence is very high. Why? Is due to depletion of the sulfhydryl group within the vascular smooth muscles. So that is a very important. Sulfhydryl group is very important to activate this drug. So when that is depleted, you will find that you can the drug will become ineffective. What drug can improve the availability of sulfhydryl group?
N-acetylcysteine.
N-acetylcysteine, very good. 2 hours of drug-free period or infusion of N-acetylcysteine will provide stuff. So sulfhydryl group has got the capacity to regenerate. So if you are using NTG for the purpose of reducing the blood pressure and increasing coronary blood flow, don't use it on a continuous basis. Give a time gap in between so that the sulfhydryl group will regenerate and you will have continuous effective functioning of the NTG. Otherwise, you will have to increase the dose. That is not desirable. Coming to suxamethonium, it's a very commonly given drug. It's also available in vials as well as ampoules. It's a chloride salt. Any other salt was there prepared earlier, which was marketed as a powder? Answer brilliantly in the exam. Some examiners may try to ask you these questions. So commonly,
Can I answer, sir?
yeah, not for you. You already proved to be brilliant. Bromide, suxamethonium bromide was available when we were all postgraduates like Dr. Vasanthi and myself, and it used to be marketed as a powder. And one good quality about the suxamethonium bromide is it is miscible with thiopentone. Whereas if you mix suxamethonium and thiopentone, what can happen? This succinyl chloride that is available, can you mix it with thiopentone?
It will precipitate, sir.
Yeah, why it precipitates? Very
Because
good.
it is the alkaline drug. The pH is around 10.
Yes. Thiopentone is alkaline and the suxamethonium is acidic. So whenever you mix that, it precipitate. But if you continue to draw thiopentone after initial loading of suxamethonium in the syringe, initially it will precipitate, but finally you will find that that will get also dissolved. If you take 10 ml of 2.5% thiopentone. Whereas suxamethonium bromide was marketed for a short period in those days to make it miscible with thiopentone for rapid sequence induction, so that you don't have to waste time injecting 2 different drugs. Okay, 2 different syringes. So you can mix the whole thing in one shot and go for RSA. So that was the indication. Now it is totally not available, and you don't have the bother and you don't answer this question in the examination. But remember about what are all the side effects of suxamethonium. Now, how are drugs causing neuromuscular blockade classified?
Non-depolarizing muscle relaxant, depolarizing
This is
muscle
the
relaxant.
common way in which every student will answer, non-depolarizer and depolarizer. But it can cause neuromuscular blockade without these drugs also, non-depolarizer or depolarizer. What are the other mechanisms by which you can cause
Central peripheral.
central and peripheral? What do you mean by that? What is central? I have heard central and ignore. Central and peripheral. So acetylcholine synthesis can be blocked, like a poison called hemicholine. Okay, so it is one of the drugs which can block the synthesis of acetylcholine, which is the main transmitter at the neuromuscular junction, and it can also prevent the release of acetylcholine, like your magnesium sulfate, which you are using in patients with preeclampsia. It causes decreased motor activity and muscular junction stimulation by preventing the release of acetylcholine. It contracts the calcium, which is required to release the acetylcholine. Okay, and aminoglycosides, all your antibiotic aminoglycosides that you use, their mode of action to cause neuromuscular blockade is by prevention of release of acetylcholine, and botulinum toxin that also causes prevention of acetylcholine release. This will also result in motor blockade, and we can deplete the acetylcholine stores. Like as you, supposing somebody gets an infection of tetanus, by repeated initial firing, you will exhaust all the stores of acetylcholine, and finally patient will die of neuromuscular paralysis. Even though initially you will be having violent contractions, all the AC stores will be depleted. And lastly, only you have to go for the drugs which we purposely use in anesthesia. Okay, so don't immediately jump to depolarizing and non-depolarizing answer. There are other methods by which neuromuscular blockade can be achieved. One by preventing the synthesis of acetylcholine, or preventing the release of acetylcholine, or exhausting the stores of formed acetylcholine, or finally blocking the action of acetylcholine on the receptor. These are four mechanisms by which you can block. So one of the mechanisms is using the neuromuscular blocking drugs. What are the side effects of succinylcholine? Very common question.
Muscle fasciculation, post-operative muscle pain,
Myalgia. Okay.
myalgia.
Now, myalgia, they can ask you one question. Who are all the people who will get this myalgia? Will everyone get myalgia when you use succinylcholine, or is it very particularly more severe in some type
Muscular build, sir.
muscular patients? Very good. For one, any other reason to get myalgia? Early ambulation, okay, especially if you use daycare. Succinylcholine used in daycare surgery and send the patient home the same day. Early ambulation aggravates the myalgia. So muscular patients, especially male patients, or early ambulation of any patient of any gender, whether male or female, are the two reasons for causing the succinylcholine-induced myalgia. Number one. Okay. Any other?
Bradycardia.
Sir, it can cause malignant hyperthermia.
Very good. That is the last word to be told. Okay.
Bradycardia.
Bradycardia.
Histamine release
First
also.
dose does not cause bradycardia. Repeated doses, especially in pediatrics, will cause bradycardia. Okay.
Hyperkalemia.
Hyperkalemia. Very good.
Yes.
That is very important, especially for all the patients who are prone
Burns.
to hyperkalemia.
Post-burns patient, prolonged bedridden patient.
Muscular dystrophies also, sir.
That is yes.
Patient having CBA, prolonged immobilization.
Yeah, let's see what's good.
Burns
Patient, neuromuscular disease patient with prolonged bedridden or paralysis. Okay, all these patients have. Why they develop hyperkalemia? That's the next question that may follow.
Because of development of extrajunctional receptors.
Fantastic. This is the reason why they develop more extrajunctional receptors, from which muscle will get stimulated and potassium will come. Very good. So this is another one. So you can remember about 8 complications are there, side effects. Myalgia, arrhythmias, hyperkalemia, increase in intraocular pressure, increase in intragastric pressure, anaphylaxis, scoline apnea is a very, very important thing. And they may ask you all questions about scoline apnea. How does scoline apnea happen?
Because of deficiency of pseudocholinesterase in pregnant patient having liver disease, renal diseases also. So because of that, this
They may
there will
get
be
prolonged extended apnea, but total
apnea.
apnea, which patient will have prolonged and total apnea?
Congenital deficiency of
This
pseudocholinesterase.
is atypical. So the answer for that is atypical cholinesterase. Patients with atypical. It is not normal in them. So the patient who have atypical cholinesterase, they will not be able to metabolize the choline that is injected. So choline will remain for a long time in their body. What is the method of treating scoline apnea? Supposing we have given scoline for a patient without knowing that it can cause
Fresh frozen plasma transfusion.
First is supportive therapy.
Supportive
The
therapy.
patient is not fully paralyzed and not breathing after scoline. You continue to ventilate them and also maintain anesthesia, because if you just give them oxygen and ventilate, they will wake up from the induction agent that you have given. They will be conscious, but they will be paralyzed. So it will cause a severe sympathetic storm. So you should maintain some anesthesia either by intravenous midazolam or volatile anesthetic agents or your nitrous oxide. Maintain anesthesia till the patient regains muscle power. Okay, that's very, very important. And continue the ventilation. And in case if you give fresh frozen plasma, that may contain the plasma cholinesterase, which can eliminate. What are the steps in the metabolism of choline? How is choline metabolized in our body by the plasma cholinesterase? This is the structure of choline. These are all the questions that may come if they ask you about choline apnea.
Two acetylcholine bond together.
Choline is a combination of
Choline,
molecules of acetylcholine.
Acetylcholine.
Dicholine. It is also called succinyl dicholine. Nothing but two molecules of acetylcholine combined by an ester bondage. Okay, that is succinylcholine or choline. And it is broken down to succinyl monocholine first, and then succinic acid and choline. These are the three steps. Succinyl dicholine broken down to succinyl monocholine, broken down to succinic acid and choline. And the first phase is rapid. From succinyl dicholine to succinyl monocholine, it's a very rapid phase, so it's called rapid hydrolysis. Then subsequent breakdown of succinyl monocholine to succinic acid and choline is called slow hydrolysis. Okay. So this is how it is. Does it produce muscle relaxation? Succinylcholine. What is the mechanism by which it produces muscle relaxation? You say it is a depolarizing muscle relaxation. So that is why it causes that all that vesiculation, because it resembles the structure of acetylcholine. It is able to go and occupy the same receptor sites, the alpha ends of the ligand channel, and block the entry of sodium. Initially, it opens the channel and allows some sodium to go in, so you get the vesiculation. But how does it cause the paralysis?
Because it is not hydrolyzed by the acetylcholinesterase.
Okay. Is
It
the
is
channel
hydrolyzed by
open or closed? Once succinylcholine goes and occupies the receptor, the alpha receptors, just like your normal acetylcholine, it opens the channel, allows some sodium to go in, you get the vesiculation. But after the patient is totally paralyzed, not able to move, not able to breathe. How does it happen when the channel is open? Sodium will have to continue going in, isn't it?
Once it enters the cell, it causes the ryanodine receptor to open and causes the calcium to go back into the cytoplasmic reticulum. So it causes prolonged paralysis of the muscle.
Ryanodine receptor has no role in choline action.
Persistent depolarization.
Due to change of the sodium channel to inactive states.
Yes.
Good. So what do you understand by that inactive state?
Instead, even if it is channel is open, the lower channel, the lower part of the channel will have another gate which will be closed, sir.
See, there are two gates. Whenever you talk about voltage gated channels, whether it is sodium channel or chloride channel or calcium channel, all these voltage gated channels have got two gates, one at the upper extracellular side, another in the intracellular side, because they are called membrane spanning receptors. So they occupy a place in the cell membrane, in any cell membrane. Here it is the muscle cell membrane. So there is a gate projecting outside the extracellular cytosol of the membrane. Okay, and there is a gate inside the projecting towards the cytosol. That as soon as the ligand comes and occupies the alpha subunit of the gate of the channel, the upper gate will open and also the lower gate will open, and the ligand, the ion can travel through that. And as long as there is a occupation of the ligand, the upper gate will remain open always. Unless you remove that ligand, that upper gate cannot close. On the contrary, the lower gate, which is facing the cytosol, is a time-bound gate. So after a particular milliseconds of time, it will automatically close, even if the upper gate is open. I am going to show you a picture later on for one of the other descriptions where you will be able to understand. So once the lower time gate closes, any traversing of the ions cannot take place. So when you give succinylcholine, because it resembles the acetylcholine molecule, it will come and occupy both the alpha subunits of this ligand gated channel. It will make both the gates open. Sodium will be able to enter. This causes the vasculation. Okay. Once the particular time is over, the lower gate will close. So no further sodium can come in to continue the contraction. So what will happen? Muscle will become paralyzed. So it goes into a state of inactivity. So there are three positions these gates can happen. One is completely closed, where both the upper gate and lower gate are blocked, closed. Second is open, where both the upper and lower gates are open, so that the ion can travel. The third position is upper gate is open, lower gate is closed, which is called inactive gate, inactive position. So that position will be achieved by the after you administer succinylcholine, and that is why they do. Please don't say about ryanodine receptor here at all. Ryanodine receptor has got no role to play in the paralysis produced by succinylcholine. It has got a role only in the production of malignant hyperthermia. Because in malignant hyperthermia, the ryanodine receptor is mutated. It is not normal. Just like you are atypical plasmatolysis, you have an atypical ryanodine receptor. And that what will happen once there is a stimulation and calcium enters through the T channel into a muscle cell, it will usually stimulate the release of calcium from the sarcoplasmic reticulum by the control by the ryanodine receptor. After the one contraction is completed, calcium will be reabsorbed into the sarcoplasmic reticulum. That does not happen in cases of patients with malignant hyperthermia because this ryanodine receptor remains open, allowing more and more calcium to come in and continue the contraction. That is why the patient goes in for muscle rigidity. Even at the time of induction, when you try to do the scoping, you will find the concentric muscles are spastic. You are not able to open. That itself is an indication that patient is likely to go for hyperthermia. So when you give choline and the patient is not relaxed at the jaw, the suspect may be having or going in for malignant hyperthermia. So ryanodine receptor's role is only there in malignant hyperthermia and not in the day-to-day action of choline. Remember, madam, who answered that as ryanodine, please forget that concept, remember this problem. Okay. And what are the contraindications for the use of sulfamethonium?
Avoided in
Hyperkalemia,
hyperkalemia.
Hyperkalemic states like CKD, muscle burn, trauma, history of muscle malignant hyperthermia, scoliosis apnea, spinal cord injuries, all these things are contraindications. Coming to cisatracurium and natracurium, we have that as a 10 milligram in 5 ml, so 2 milligram per ml. I've got natracurium becylate injection, is also available as 2.5 ml ampoules. Natracurium is available as ampoules, cisatracurium and vials. So, how many stereoisomers are there in natracurium and why? There are 10 stereoisomers in natracurium because it has 4 aryl molecules. And what is Hoffman degradation? This is a very common question. The metabolism of natracurium. What is Hoffman degradation and what are the metabolic products of natracurium?
Non-enzymatic, temperature dependent
Temperature and pH dependent.
pH.
Spontaneous degradation of a compound due to variations in body pH and temperature is called Hoffman degradation or elimination. Spontaneous degradation, no enzymatic activity is required. So spontaneously, because body cannot maintain the same pH and same temperature minute to minute or second to second. There will be subtle variations depending upon our day-to-day respiratory activity, metabolic activity, all these things. So these small changes in the pH as well as temperature will make the drug spontaneously undergo degradation. That is called Hoffman degradation or elimination. The metabolic products are Adenosine and quaternary monoacrylate. These are the the other routes of elimination. What are the other metabolites that are produced by this drug is eliminated? Hoffman elimination is the major route of elimination. What are the other routes of elimination?
Non-ester hydrolysis.
Other routes are ester hydrolysis by non-specific extrases, again into Adenosine, quaternary alcohol and quaternary acid. So here it is monoacrylate by the Hoffman elimination. In addition to Adenosine, you get what is called quaternary monoacrylate, whereas in the ester elimination, you get a quaternary alcohol and quaternary acid. Between cisatracurium and natracurium, which has a faster onset of action and why? When you give natracurium and cisatracurium for intubation, which patient you will be intubate faster?
Cisatracurium.
Confident? Can lock the answer.
Natracurium.
Natracurium has a faster onset of action because cisatracurium, it has a higher dose, 0.5 milligram per mg. Okay? Whereas cisatracurium, you give only 0.15 milligram per mg. So, another you have to give a more potent drug given at a lower dose will have a slower action. Less potent drug given at a higher dose will always have a faster action. That is the basis in your pharmacology. Okay, lower potency but higher dose, faster action. Higher potency, lower dose, slower action. Onset. Okay, so remember, natracurium will always be faster. Coming to anticholinesterases. Classify the types of anticholinesterases. Competitive antagonism. Okay. Heterophonium, so the drug is mainly used for diagnostic purposes. Then those which form carbonylated enzyme complex like neostigmine and pyridostigmine. Irreversible action of acetylcholinesterase like organophosphorus compounds. So we have 3 different classes of even though you are only familiar with neostigmine because you are using it day in and day out for your reversal. But these are the other drugs about which also you should know. They all act against the enzyme cholinesterase. So they are called classified into drugs as anticholinesterases. So the first drug was detected was actually Hydroponium, which is a competitive antagonist. And this was used mainly to diagnose myasthenia gravis, okay, as a competitor for the anticholinesterase and produce availability of acetylcholine. Then you started using neostigmine and pyridostigmine. Then another OPC poisoning occurs that also blocks the action of acetylcholinesterase and causes severe stimulation of acetylcholine. So you get all features of severe parasympathetic stimulation. Okay. So the neostigmine that you use. So what are the types of acetylcholine receptors and why they were named like that? What category they belong to?
Muscarine and nicotinic.
Very good. There are two types. Why they are named like that? So acetylcholine receptors can be classified into nicotinic and muscarinic. They were named after the ligand which were first found to bind with them. The nicotine, whichever receptor which avidly bound to nicotine that is found in your cigarettes, that was called nicotinic. And the muscarine is a mushroom poison. So, country mushroom. We use mushroom for food also. But a poisonous variety of mushroom has got a ligand called muscarine. So those which bound to that avidly to the muscarine, they call muscarinic receptors. So nicotinic receptor is the ligand-gated ion channel receptor, whereas muscarinic receptors are G protein coupled receptors. So this is another important difference that you should know. So this is how they are. So whenever you talk about the muscarinic receptor, this is the G protein coupled receptor or serpentine receptor or 7-pass receptor. There are so many names for this, not only called as the G protein couple, but also there are 7 passages or 7 passes. So there will be a ligand binding site outside extracellularly. From that it will come, go through all these things, and then internally it will activate the G protein. So the G protein is present intracellularly in the cytoplasm attached to the cellular portion. So that will be broken down. The G protein is a heterotrimeric protein. They've got a alpha subunit and a beta gamma dimer. It is in 3 parts that will be activated. So that is the basic structure of G protein. Whereas ligand gated, you have to just attach yourself to the alpha subunit and then you will go to the channel to allow the ions to traverse. So what are the uses of anticholinesterases? Where do you use all these drugs? Because OPC is a poison, you don't use it as a drug, but neostigmine, hydroponium, pyridostigmine, all these things are clinically used. What are the uses? So used to reverse the residual effect of your neuromuscular blocking drugs. Neostigmine you are using. And you can also use them to treat myasthenia gravis, okay? To make the more acetylcholine available, to enhance the neuromuscular transmission. The main two clinical usages are to reverse the effects of residual neuromuscular blockade. Also use the treatment of myasthenia gravis. Another important drug we are commonly using, antiemetics. So what is the definition of vomiting? How do you define vomiting? Vomiting is defined as retching followed by expulsion of gastric contents. That is the definition of vomiting. The retching followed by expulsion of gastric contents. So name the different input to vomiting centers, the receptors and their location. The vomiting center is not activated by one particular source. There are several sources or locations from the body where from which the vomiting center can be stimulated to produce your vomiting. So you have to these are all the can be from cerebral cortex, peripheral, GI tract, liver and gastrointestinal tract, receptor, bone, and vestibular area. So all these things they have their input, but finally it will all have to concentrate on the vomiting center in the medulla, which has got acetylcholine muscarinic receptors. It is responsible responding to histamine 1 receptor. It responds to 5-hydroxytryptamine receptor, 2 receptor, NK1 receptors. All these receptors can stimulate and produce nausea and vomiting. So, but the dexamethasone is the odd man out here. How does it help in vomiting? Very recently, almost about 5-6 years, they found out that dexamethasone is very useful in preventing vomiting. But their mechanism of action, that's why the anti-inflammatory effect which it produces, and it has got a direct central action at the solitary tractus nucleus. It interacts with the neurotransmitter serotonin and receptors protein kinase, NK1 and NK2, alpha-adrenaline. All these things are postulated. Nobody knows exactly how glucocorticoids or dexamethasone help. But the possible mechanisms they have identified are its anti-inflammatory effect, direct central action on solitary nucleus, interacting with neurotransmitter serotonin. Also maintaining normal physiological functions of organs and systems, which also act as a trigger for nausea and vomiting. And regulation of hypothalamic pituitary adrenal axis, reducing pain and concomitant use of opioids, which are all possible mechanisms for that. How does metoclopramide helps in vomiting?
Prokinetic drug, which will increase the gastric
Block the central dopamine receptors in the chemoreceptor trigger bone. Okay, so chemoreceptor trigger bone has got dopamine 2 receptors, so that's a central action, and also acts on the peripheral dopamine receptors, which cause prokinetic effect on the stomach. So the dopamine receptors which are present on the stomach, they enhance stomach contraction. Whereas the centrally present D2 receptor, this is D1, peripheral one is the D1, central one is the D2. So D2 has direct antiemetic effect, whereas D1 is more prokinetic effect on the stomach and augments peripheral cholinergic receptor, and also has got a mild effect on the 5-hydroxytryptamine receptor also. These are all the mechanisms. What is the unwanted side effect of metoclopramide?
Extrapyramidal side effects.
Fantastic. Extrapyramidal side effects. This is another common drug which can be asked in the examination. That's all. Every day, everybody will be using it. Using PA or even if you are doing any original procedure, a common drug used for sedation. So, what category it belongs to? The benzodiazepine group of drugs. Okay. What are its actions and how they are caused? How is it causing its action?
It acts on the GABA receptors, sir.
Very good. Action on the all benzodiazepine act on both GABA A and GABA B receptors. Okay. So what will result? What will happen if they act on that or if they get attached to the GABA A?
Hyperpolarization leading to the chloride
Hyperpolarization.
channel open.
Opens the channel, chloride channel, and leads to hyperpolarization.
Polarization of the chloride channel, sir.
Hyperpolarization of not chloride. Negative chloride go into the cell and cause inside the negativity. That is called hyperpolarization. Not hyperpolarization of the negative channel. See, the channel for chloride opens by binding of these drugs onto the GABA receptors, alpha subunit. It's also a ligand-gated channel. So just like sodium coming in at the neuromuscular junction and acetylcholine binds to the alpha receptors, here what happens, the benzodiazepine, they have a separate site for binding. Unlike your GABA, which is a which has got their own type of binding. Once it binds, what happens? It will open the channel. Chloride will start going in. And the more negatively charged chloride going inside the cell will make it more negative. That is what is called hyperpolarization. Increased negativity. Normally itself, compared to the outside, cell inside is electronegative. Okay? This negativity becomes much more hyper. That's why then it becomes hyperpolarized. Okay? So you should not say it is hyperpolarizing the channel. It doesn't the channel is not getting hyperpolarized. The side of the cell is getting hyperpolarized. Okay? It is becoming more negative. Right. So that is how the action is caused. Causes also hypnosis and anxiolysis. By GABA A and GABA B receptor. How is it presented? What is the characteristic of the solution that you find in the vials or ampules? Is it water soluble or lipid soluble, watery or thick?
Water soluble, clear colorless solution
Clear colorless
presented
solution. Very
in
good.
amber colored bottles.
What is the pH? What is the pH of this solution that is located? It is 3.5 acidic. Most of the, I have told you in the earlier class, all liquid preparations will only have acidic pH. So even if you don't remember the number, you will say acidic, the examiner will accept. So you don't have to exactly remember whether it is 4 or 4.2 or 3.5. You say it is acidic. What is the peculiarity of the structure of midazolam?
It's a pH
Midazolam has
dependent
got a very
ring open.
peculiar nature in its structure. What is that?
pH dependent ring
It has,
open.
imidazole ring, sir.
Midazole ring.
In acidic pH, it will act as a lipid soluble drug, sir, and in alkaline pH, it will act as a water soluble drug.
Opposite. Structure is dependent on the surrounding pH. First and foremost answer, the structure of midazolam is dependent on the surrounding pH or the medium in which the drug is present. In the bottle where the pH is 3.5, okay, the ring structure is open, making it an ionized molecule. So whenever you say a molecule is ionized, what will you understand? Can it penetrate the any cell membrane?
No, sir.
Cannot penetrate.
It cannot, because it is having a electrical charge. So when you say a molecule is ionized, that means it is having an electrical charge, it will be repelled, it cannot enter. So at this pH, it is water soluble. That's why it is like a clear colorless solution. Okay. But when it is injected into the body, our body pH is more than 3.5. Blood is 7.35 to 7.45, isn't it? So when the pH becomes more than 4, the ring structure closes, making it unionized. That is, it loses the electrical charge and becomes unionized and becomes lipid soluble. Okay. So in the bottle, remember it is a clear colorless like a water solution, so it is water soluble. In the body we have lot of fat, so it becomes fat soluble. So remember that we don't confuse between these two. When it is ionized in the bottle, it cannot enter the cell directly. So it is water soluble. When it enters our body, when you inject it into the becomes unionized, lipid soluble. So at physiological pH, almost 89% is unionized, resulting in the faster onset of action. That is why when you give midazolam 1 or 2 milligrams and try to load the other drug, the patient will be half asleep. So the speed of onset is mainly because once it goes into the body, it becomes unionized, easily enters the neuronal cell membranes and cause their action of GABA potentiation and then causes this sedation. So this is picture will tell you how nicely at the this is the ring which is open here. You can see the amine, the fluoride and all these things. There's no communication here. So less than 4 pH, this ring is open. Once it becomes the pH is higher, the ring has closed. So that you don't find any open discontinuity at all. So this closed form becomes lipid soluble. This open form is water soluble. That is what change occurs. So what is this mechanism called? In this property of midazolam called?
Tautomerism.
Excellent. This is also called tautomerism, otherwise known as dynamic isomerism. Okay. So this is what you have to clearly understand. So whenever midazolam is given, they will definitely ask you about tautomerism, and this is the basis you have to remember in your life, because usually this drug in your practice. Now this is
amnesia, sir.
yeah, hypnosis, sedation, and amnesia, all this the actions of this drug. And diazepam is the earlier introduction of benzodiazepine, which is the first one to be introduced in clinical practice. So, a common question they may ask you is compare the drug with midazolam, diazepam and midazolam. What are all the advantages of midazolam over diazepam?
Diazepam, it causes pain on injection.
Excellent.
More
oily
solution, sir.
very
It's a
difficult.
long-acting oily solution, sir.
It's a longer acting drug, sir.
Points. So more rapid onset with midazolam.
Midazolam has rapid onset of action, sir.
Greater amnesia. 2 to 3 times more potent. Midazolam is more potent than diazepam. Twice affinity for benzodiazepine receptor. Greater decrease. Midazolam causes the greater decrease in blood pressure and heart rate compared to diazepam. And similarly, systemic vascular resistance also decrease more by midazolam than diazepam. Less post-procedural sedation. It is once you, because it is rapidly eliminated also, patient recovers faster compared to diazepam. Whereas diazepam sedation will last longer. But complete recovery, both the drugs take the same time. That is the only common thing between these two drugs. How is diazepam overdose treated? What is the antidote for it? This may be the sudden surprise question for you. You are thinking to answer all of them.
Flumazenil.
Flumazenil. Okay. So what is the, supposing you find a patient has swallowed 500 tablets of diazepam, what will happen to that patient? Will they die? They have respiratory depression, will they be in coma?
No, sir, they will sleep. They will sleep, sir.
They will be sleeping for a long time because the safety margin, therapeutic safety margin
It's high for
is very, very high for diazepam. Okay? Normally, by taking overdose of diazepam, nobody will die. Okay? They may have some prolonged sleepiness, some amount of respiratory depression may be there, but death due to overdosage of diazepam is very, 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 very rare. Okay? So, the treatment will be mainly supportive, and the antidote is flumazenil, and you start a dose of 0.1 milligram IV bolus and go up to 0.3 to 0.6 IV depending upon the dosage of consumption of diazepam. Okay? How long does flumazenil act? What is the duration of action of flumazenil? Is it a long-acting drug or a short-acting drug? It's a very short-acting drug. Okay? This is available in this sort of vials, 0.1 milligram per milligram in a 5 ml, 20 milligram. So the duration is quite short, so you may have to repeat it. If the patient is still drowsy and sleepy, you may have to repeat the dose again and again. What is the danger of or side effect of this drug? When do you use diazepam? Any acute condition can you use diazepam apart from anesthesia?
Control of convulsions, sir.
Seizure. So diazepam is a very potent anti-epileptic drug. So when a patient is having overdose of diazepam, and this drug tries to remove that. Can the cerebral cells get irritated? So one of the important side effect of this is seizures. So fumagazine, when you give, it may by itself produce seizures. So you have to be very, very careful. Mr. Fumagazine, especially if the patient is a known epileptic and he has taken overdose of diazepam, and you treat that patient with fumagazine, we can throw a convulsion. Okay, very, very important. Now, this is another drug. When we talked about epilepsy, you have to know about this drug, which you will be commonly using in your ICU, Phenytoin injection. What are the uses of Phenytoin?
Anti-epileptic drugs, sir.
Yes, very good. So, used in the treatment of grand mal seizures, trigeminal neuralgia, pain medicine. You know, the substitute or the alternate for carbamazepine for trigeminal neuralgia. Also very useful in the treatment of ventricular arrhythmia caused by tricyclic antidepressant overdosages. Okay. Also, digoxin induced. Sometimes digoxin can cause arrhythmias by itself. So that arrhythmia also can be treated by Phenytoin. The mechanism of action of Phenytoin. How does it act? Say it is an anti-epileptic drug. So how does it produce?
GABA B agonist.
GABA B agonist. GABA B agonist. Does it have anti-epilepsy? This is where you have to remember the sodium channel, what I told you. This picture will tell you a clear idea. Sodium entry is the main important reason for depolarization and conduction of action potential, isn't it? So, when a sodium channel is closed, you find that this is the outer channel. This cell membrane, this is extracellular, this is intracellular. So, there are two gates. This is the voltage dependent gate, this is the time dependent gate. Okay. So, at the resting stage or when the channel is closed, you find this voltage dependent gate is closed, this time dependent gate is open. So here sodium comes and occupies the channel. At the time what happens? Both the gates are open. So sodium is able to enter. But after the initial stimulation, this is a time dependent gate. So this gate will immediately close after the allowing a few ions to go in. Once the time sequence is over, the inner gate will close. And even if the outer gate is open because of the occupation of the ligands here, sodium cannot come in. This is what is called the inactive state. Okay? So, the Phenytoin acts mainly on the sodium channel, which is in the inactive state, by occupying this so that it can prolong the, prevent the depolarization. Another mechanism is it may also reduce calcium entry into neurons, thereby blocking transmitter release and enhance actions of GABA. Okay? So that is how the second mechanism is there. So under what class of antiarrhythmic drugs you will classify Phenytoin into?
Class 1.
Class 1, there are sub-classification.
A, B.
B. Class 1B. Okay. So class 1A, what are the examples? Your local anesthetic agents. Class 1C, with the fexilitrin and all other things. So there are 3 subclasses in class 1 itself, which are all sodium blocking agents. Okay. So Phenytoin acts as a class 1B antiarrhythmic drug. Another drug which is used rarely but also may be asked in the exam is, what is this drug? There are 2 preparations, 20%, 25%, even 10% is available. 100 ml, 50 ml. What is Mannitol?
Osmotic diuretic.
Excellent. Osmotic diuretic. Okay. What are the uses? Where do you use
Sir, head injury, control of intracranial pressure. Sir,
with a paired blood-brain barrier? Can you use Mannitol? Head injury as a first indication. Is it indicated in head injury or tumor?
yes,
Cerebral edema.
cerebral edema, sir.
Ah,
And it's also
that-
jaundice patient.
Okay. So,
Is also using hepatic failure, sir.
to reduce ICP during neurosurgical procedures. That is a very common indication. If you have done neurosurgery training time, you would have seen. Whenever the surgeon says the dura is bulging, I want the lax brain. One of the methods to reduce the ICP is using mannitol. Okay? Reduce IOP during ophthalmic surgery. So some of the glaucoma patients, when they come for surgery, the surgeon might wish to give mannitol first and then wait for a few minutes and then take up the patient to reduce the IOP. And to preserve renal function in jaundice patients, okay, is given especially obstructive jaundice patients coming for any surgical procedure. It is better to give them a mannitol treatment to keep the kidneys flush so that there is no deposition of all the products in the kidney of causing acute block. Promote diuresis in donor during renal transplant. Give mannitol after the starting of the vascular dissection, the donor transplantation being done. And to promote renal function during aortic surgery after clamp release. In all these patients, what is the half-life of mannitol? It's about 100 minutes. It is about maybe half hours, little extra, 1.5 hours. Another drug we all are familiar with is Lasix, furosemide. What category of drug is this? What is the mode of action of Lasix?
Sodium potassium chloride channel.
Co-transporter. It inhibits the reabsorption of sodium chloride in the thick ascending loop of Henle and to some extent in the early part of the distal convoluted tube. Okay. So the site of action you have to remember. It acts on the thick ascending loop of Henle. That is why it's called a loop diuretic. Okay. So if you remember the name loop diuretic, you can remember that it acts on the thick ascending loop of Henle and to some extent in the early part of the distal convoluted tube. The action impairs countercurrent multiplier system to reduce the medullary hypertonicity, causing reduced reabsorption of water. So more water is greater. Why it is called Lasix?
It lasts for 6 seconds, 6 hours.
The action lasts for 6 hours. So they took the LA from last in 6 hours. So the point told by my medicine assistant way back when the drug was introduced in 1967. That's the time it was introduced. The time my assistant taught me this. It's called acid action lasts for 6 hours. So these are all some of the drugs. I have touched, not covered everything that is there, but as a part of your just training, you have to remember that drugs can be asked based on the first classification. I told you induction agent, analgesics, hypnotic sedatives, then neuromuscular blocking agents, then your local anesthetic agents like that. You have to remember all the categories of drugs from which you can be asked questions. So I have tried to cover as much as possible within the short time. You have only 2 weeks to go for your exam. So this completes a little bit of a small trial or training for you to answer your questions with regard to the drug in the examination. Now coming to the IV fluids, they may just show you some IV fluids and then ask you what are the things. But all of you, I think, will have a basic knowledge of the fluid compartments and the fluid status of our body, not in your basic physiology your examination. So, what are the purposes of IV fluid administration? Why do we give IV fluids? To maintain tissue perfusion and electrolyte concentrations, the compositions of various IV fluids that are commonly used that may be asked. So, can you just enumerate what are all the IV fluids that you are using in your day-to-day practice, or you have so far used in your entire 3 years of training? Commonly, what is the common IV fluid you use day in and day out?
Commonly, we use crystalloids, sir. Like Ringerlactate.
Ringerlactate, I think majority would have used Ringerlactate. And what is the next commonest drug you would have, fluid you would have used?
Normal saline, sir.
Normal saline, very good. Then
dextrose 5%.
dextrose in normal saline, very good. Then
and DNS, sir.
That is dextrose in normal saline.
Yeah, dextrose 5% also sometimes.
Yeah, I have 5% dextrose. That is another category. So fourth category is 5% dextrose, which you rarely use if you suspect or if you
then
a small child where you don't want hypoglycemia to happen. Okay. So commonly Ringerlactate or normal saline or dextrose in normal saline and the dextrose in water. These are the four.
Then plasma light and isolite.
If you are in a corporate hospital or if your hospital can afford a little more expensive fluid, you will use plasma light. Okay. What are the rare fluids that you will be using?
Sir,
or
now
you are at least seen. Are you using half normal saline every day?
No, sir.
No. In some circumstances, you will be using half normal saline. Okay. And are you using an isolate G, isolate M, isolate P? All these things?
No, sir. Isolate P sometimes we use in children.
Isolate P was once upon a time introduced as mainly for pediatric use. Now it is being ridiculed and banned. Discouraged. Why? So if you say isolate P pediatric use, the examiner is about to ask you this question. Why they don't prefer to use isolate P for pediatric? When pediatric anesthetists say, pediatric anesthetists who calls it as not as isolate P for pediatric, but it is isolate P poison.
Hypotonic.
It is hypotonic. So whenever you have to choose an IV fluid, what are the criteria you should know how to choose that fluid? What is the how do you make your selection of IV fluids?
So its composition should be near to our plasma, sir.
Should be isotonic as much as possible, correct?
It should not affect our clotting mechanism, sir.
Very good. Okay. Should not interfere with
and it should not, sir, causes the cardiac failure or congestive cardiac failure, fluid overload, sir.
Right. Okay. So these are all the criteria by which you select. Now, what is the difference between tonicity and osmolality? You use these two terminologies commonly whenever you talk about IV fluids. You say it is osmolality is so much, osmolality is so much. You say it is isotonic, you say hypotonic, hypertonic. What is the difference? Is there a difference between these two terms or they can be used interchangeably?
If the osmolarity is more than plasma, then we call this hypertonic, sir.
Why not hyperosmolar? You have to call it as hyperosmolar. Okay. When the osmolarity is more than plasma, you should call it as hyperosmolar or hypoosmolar or isoosmolar. Why you have to have a terminology called isotonic, hypotonic, isotonic? So this is the common composition of all the IV fluids that we use. No? Now, it is better to know what is the composition or the characteristic of our extracellular fluid. Now, all the fluid in our body, all of you must be knowing, is divided into intracellular fluid and extracellular fluid. Correct? What is the quantum of intracellular fluid in a person?
42% is extracellular fluid, sir.
Two-third of the person's body weight is intracellular. And 1/3 is extracellular. I think because we are made up of cells, we have a lot of cells. So more percentage of fluid will be inside the cell. So intracellular fluid is 2/3 and extracellular fluid is 1/3 of the body weight. The common example they will give you is, if supposing you have a 70 kg person, what is his body, how much of his body is composed of water? The total body water percentage for a 70 kg man.
60%.
60%, yes. So 60% will be so 60% of the body will be made of water. Okay. The rest 40% is by all the other tissues, bones, and other things. So they are 60% is water, fluids. Of this, 2/3 will be inside the cell, and 1/3 only will be outside the cell. So what is that? 40% will be inside the cell, and 20% will be outside the cell. Okay, and that extracellular compartment, how it is divided into
Intravascular and extracellular.
plus interstitial and intravascular.
Interstitial and intravascular, sir.
Any other compartment is there other than these two major compartments? There is another category called transcellular. Okay, the third category in extracellular is intravascular, interstitial, and transcellular. These are transcellular. Can you give me examples of transcellular fluids which are extracellular?
Cardiac fluids, sir.
Pericardial fluid, pleural,
gastric, pleural, conjunctival, then tear. All these things are transcellular fluids. Okay? So, but because of the small quantity, we normally don't take that into account. So, we classify the extracellular fluid into intravascular and interstitial fluid. So, interstitial acts as a bridge between intravascular and intracellular. So, any fluid which is infused into the intravascular compartment first has to traverse through the interstitial space and then enter the intracellular space. Vice versa, it can come out from the intracellular to the interstitial and then enter the intravascular space. So this is the normal mode of transmission or movement of the fluid. Okay? So what percentage of extracellular fluid is comprised by the intravascular compartment? Out of the 1/3 of the extracellular ECF, how much is the intravascular? And how much is interstitial? 1/4 of the extracellular, that is 25% of the extracellular fluid is intravascular. Remaining 75% is interstitial. So that is why we must know the characteristics of this extracellular fluid, because all the IV fluids we are going to inject into the intravascular compartment. So when it matches the extracellular fluid characteristic, it will stay better in the intravascular compartment without going into the interstitium and then into the intracellular. Okay? So the normal osmolality of this extracellular fluid is 285 to 295 milliosmoles per liter, and the ion concentration is 142, chloride 4, calcium 5, magnesium 3, phosphate 0.3, chloride 103, bicarb 23, phosphate is 3. So all this is the normal composition of your extracellular, or indirectly you can say even intravascular. So when you take vinegar lactate, it is slightly hypotonic. Even though for all practical purposes we take it as isotonic, it is mildly hypotonic. but it has got a lower sodium. It has got normal comparable chloride, but the lactate is very much high. When you take normal saline, it is slightly hypertonic, but from 295 it is another 13 millimoles more. But for all practical purpose, both lactated ringer and saline, we consider them as isotonic. And the chloride and sodium are very, very high comparatively. Especially fluoride is very much higher compared to the normal cellular or the lactated ringer. What is the danger of having so much of chloride in the fluid?
Hyperchloremic metabolic acidosis it can cause.
So when you exceed a certain quantity of infusion of normal saline, normally they consider 1.5 to 2 liters is safe. More than that, if you continue to infuse as a normal saline 0.09%, then there is a risk of hyperchloremic metabolic acidosis being reached hypergenically. So you must avoid giving too much of normal saline to a patient. Then plasma light is almost equivalent, 294, which is 7.4. So plasma light A, which has been now recently introduced, has been found to be identical in all the values, more or less same. What you like to the extracellular compartment. So consider that as an ideal fluid. And half normal saline, you have only 50% of all the electrolytes that you are having in sodium normal saline. So this is more recommended whenever you have a cardiac problem where you don't want to use more of sodium or chloride to the patient. Then there is a dextrose with 1/4 normal saline is also there, which is still first lesser than the half normal saline, but it has got 50 milligrams of dextrose available in the per liter. And there is a 10% dextrose, which we normally use small volumes, mainly for what purpose? When will you use a 10% dextrose?
Sir, in a diabetic patient, when we give insulin in different regimes, sir, no? Alberti Thomas regime.
First answer you will always to correct hypoglycemia.
Hypoglycemia.
Okay, remember, the most important reason for using 10% or 25% dextrose is to correct hypoglycemia, which is a very dangerous situation. If you don't correct it faster, patient can have complete cerebral inactivity. So, first indication I must always say is to correct hypoglycemia. Second is to drive potassium back into the cell as a glucose insulin infusion. You can use 10% dextrose. Okay, these are the simple indications if you want to remember in the examination. Then, of course, 5% albumin. Now, what we have discussed up to this, here they are all classified as crystalloids. Albumin comes under the category of a colloid. So, what is the difference between a crystalloid and a colloid? When will you call a solution as a crystalloid solution? When will you call a solution as a colloid solution? Or what are the characteristics of a crystalloid and a colloid?
Molecular weight is high in colloid solution. They stay in the circulation for a longer period of time.
These are characteristics. Supposing somebody asks you to define a crystalloid solution and a colloid solution, how will you define them? What you are saying is the characteristic, staying in the circulation for a longer time, particle having a higher molecular substance. But if you want to define a crystalloid and a colloid, how will you define them? Crystalloid is a solution where molecules are evenly dispersed. Okay, molecules are evenly dispersed. Whereas colloid is a solution where molecules are bigger and not evenly dispersed and cannot traverse a membrane. Colloid solutions can easily traverse a membrane. Whereas, crystalloid solutions, whereas colloid solutions cannot traverse the membrane. the definition or description of the difference between a colloid and a crystalloid. Crystalloid is a solution where molecules are evenly dispersed. They are all evenly dissolved in that solution. Whereas colloids are bigger molecules, they cannot disperse themselves evenly. They will be in clusters here and there when you examine them. And the crystalloids can easily pass through any membrane, whereas colloids cannot pass through the membranes easily. So they are retained inside the vascular compartment for a longer time. Of course, we have other forms of colloids which are not mentioned here, but the albumin only I have given here because this is what is considered as an ideal colloid solution. Whereas the other things which are commonly produced earlier, they have all gone out of repute for some reason or other. But you have a lot of varieties. We will see a little later. So, what is the difference between osmolality and tonicity? That was the question I asked you earlier. So, the answer for that is osmolality is a measure of osmotic pressure of a given solution. Osmolality is the measure of osmotic pressure that solution can exert of a given solution is called osmolality. Whereas tonicity is a measure of osmotic pressure gradient between two solutions separated by a semi-permeable membrane. So whenever you talk about tonicity, you are comparing two solutions, one solution on one side, another solution on another side, separated by a membrane. Then only you should use the term tonicity. When you are talking about an individual solution, you have to talk about osmolality. You have to say this solution is, supposing somebody asks you about sodium chloride, then you have to say sodium chloride is a isoosmolar solution. You cannot say isoosmotic solution. But when you compare it with extracellular fluid, that is why in this tabular column, first we have given extracellular fluid. And when we compare it with the lactated ringer, we call it as slightly hypotonic, slightly hypertonic. So we are comparing between the two solutions. Then you use the word tonicity. When you talk individually, when you are given lactated ringer alone and asked to describe, you have to say it is isoosmolar or it is mildly hypoosmolar. You cannot say isotonic there. So whenever, is it clear what I am saying? Are you able to understand? So tonicity is the word to be used whenever you measure the osmotic pressure gradient between two solutions separated by a permeable or semi-permeable membrane. That is the method. Of course, majority of the teachers will use this as an interchangeable terminology because majority of the time you compare with other things. So, but technically speaking, this is the correct definition for the two things. Can you find the difference between these two bottles or these two preparations? Both are 0.9% sodium chloride or normal saline. Both are 500 ml. One is 1000 ml, another is 500 ml. What is the difference between these two other than what I have now told? What is very obvious here? How do you call this? What is this package called? What is this package called?
Pouch form and a bottle form.
This is a plastic bottle. This 500 ml is a plastic bottle. This is a 1000 ml collapsible bag or a sachet or a pouch, whatever you want to call it as. Okay. What is the difference between the two? Why I have put these pictures here? Is there any significance? Given a choice, supposing you want, I give you a 500 ml preparation in this pouch and 500 preparation in this bottle. Which one would you prefer?
Pouch form will be preferred, sir. More sterile during the insertion. And no need to vent out the air because it's a non-collapsible.
Is it called? And there is no need for venting or you can complete itself. It's called a closed infusion. Okay. Whenever you don't expose the IV fluid to the atmospheric air, it's called a closed infusion set. So the reason why they have all converted from the plastic bottles into these sachets or pouches or bags is the IV infusion system has been classified into closed infusion and the open infusion system. Whenever you put a vent to allow external atmospheric air to enter, to cause pressure and then push the fluid down the IV drip set, it gets chances of it getting contaminated are high. Okay, that is called open infusion system. Whenever you have this pouch and you attach a IV infusion set, the pressure inside the bag will automatically allow the fluid to go to the IV drip, and it is constructed in such a way it will nicely collapse completely and empty all the contents. You don't have to put any air inside at all. So this is called a closed IV infusion system. So that is why we are all moving more towards the pouch system, even though it is more expensive than the bottle system. This is supposed to be more sterile and more correct method of closed infusion or IV system. Okay, so that is the reason why I thought I would just do this. So how do you classify the IV fluids? This is the common question that may be asked in the examination. How do you classify? There are several methods of classifying that. But what is the common accepted method? So it can be classified into two categories based on the contents. As I told earlier, it can be a crystalloid solution or it can be a colloid solution. Or when you compare it with the other solution, you can call them as hyperosmolar, isoosmolar, or hypoosmolar. Okay, so based on that osmolarity, you can call them as hypertonic or hypoosmolar, isoosmolar. Another method some people prefer to use is maintenance solution and replacement solutions, specific purpose fluids. That is also older textbooks always say maintenance fluids, replacement fluids, and specific purpose fluids. Can you give examples of specific purpose fluids which are not regular fluids? We use them only on specific occasions, which are given only intravenously. So they are classified under intravenous fluids because they are liquids given intravenously.
NaCl.
Huh?
3% sodium chloride solution.
Hypertonic saline, 3% sodium chloride, very good. Anything else? Sodium bicarbonate, can you call that as a special IV fluid? You use it only for correcting in those days severe acidosis. They used to indicate sodium bicarbonate, which is recommended. Or correcting hyponatremia, sometimes after TURP, sodium bicarbonate is advocated. Mannitol is used as an osmotic diuretic. That is also considered as a specific purpose IV fluid. Okay, so like that you have this classification: maintenance, replacement, and specific purpose. But that is found in the olden textbooks, so I am not told that. Basically, this is the common way you can classify that. Now to just find out a small idea about how to choose the fluids, you have to remember. Supposing you use 1 liter of normal saline in the patient, and another person you are infusing 1 liter of 5% dextrose intravenously. How much of this 1 liter of normal saline will be retained in the intravascular compartment? And how much of 5% dextrose will be retained in the intravascular compartment?
Hypotonic. 5% dextrose is hypotonic.
Okay.
So it will enter the cell, sir.
Oh, the question is, it's a mathematical question. You are giving 1000 ml of normal saline to one patient and 1000 ml of 5% dextrose in water to another patient. How much of ultimately the fluid that you are given will be retained in the vascular compartment? How will you calculate that? I want specific numbers. You are giving 1000 ml. So how many ml will be available in the intravascular compartment after a few minutes when you give saline, and how much will be available when you give 5% dextrose in water? How do you calculate that? I know all the doctors are weak in mathematics, so I'll just give you the answer for that. Normal saline is isotonic, so it will distribute itself in the extracellular compartment equally, okay, because of this isotonicity. Then intravascular compartment is only 25% of the extracellular compartment. That's what I told you in the earlier. So 2/3, 1/3 between intracellular and extracellular. Extracellular 25% intravascular, 75% interstitial. So if you give 1000 ml, only 25% can be in the intravascular compartment. Okay, the rest of the 750 ml will go into the interstitial compartment. Okay, so 250 ml will be retained in the intravascular compartment when you give normal saline. At the same time, when you give 5% dextrose, what will happen? It will be metabolized. The dextrose will be metabolized immediately, and it will leave only 1000 ml of water. And this 1000 ml of water is hypotonic. Since intracellular compartment has 2/3 water and extracellular 1/3, 333 ml only will be remaining in the extracellular compartment. 667 will go intracellular, because it will immediately migrate like to the intracellular compartment. And out of this 333, which is in the extracellular, only 25% will be in the intravascular compartment. So 1/4 of this 333 will be in the intravascular, that is about 84 ml. So if you give 1 liter of 5% dextrose, only 84 ml will remain inside the vascular compartment. So, but 250 ml will remain if you do normal. Is it clear? Are you able to understand that? So that is why we always prefer to give an isotonic substance, isotonic fluid, so that it can be retained inside the vascular compartment at a greater proportion. Similarly, if you give colloid, what will happen? The colloid will have more osmotic pressure. It will try to not only retain its more volume, but will also attract fluid from the interstitials place and increase the intravascular volume. So that is why colloids are also called plasma volume expanders. They not only maintain the volume that you infuse, but also expand that volume by sucking the fluid from the interstitial compartment, and ultimately is required even from the intracellular compartment. Okay, so that's what you have to remember. Other colloids that we have to know about are the phenaxyl, yellow fusions, the dextrans, and the metastarch. These are the 4 synthetic colloids that are available. So albumin is also made synthetically now. So these are the 5 colloids that are commonly kept, and but each one has got its own drawback. Phenaxyl has got anaphylaxis. The dextrans interfere with the blood grouping and coagulation. The dextrans, in the long run, have been found to have nephrotoxic effects, and so ultimately, albumin remains as the best colloid for any resuscitation purpose. Okay. That is why I have great detail. So if they give you a bottle of IV fluid, first read the label, read the contents. They may ask you the composition. So remember the basic composition of the extracellular fluid. You can compare with that, then try to say whether it is isotonic or hypotonic or harmonic. And osmolality wise also you can say whether it is isoosmolar or hypo or hyperosmolar. And the indications are mainly for maintenance. They can ask you questions on how will you replace for the starvation period. That all belongs to the maintenance only. So we can talk to you about holiday cigar formula, replacement, how do you calculate based on the dehydration, especially in pediatric patients. These are all the questions that are commonly asked. That will give you an overall idea about how to deal with the IV fluid questions in examination. So I think that will.
Any questions from the students?
Any additions or any omissions or any clarifications, any corrections, all are welcome.
The plasma light is also being asked nowadays, no, sir?
Yeah, that is very commonly used in majority of the hospital because it is almost equal to your ECF composition. Even for renal transplant, nowadays they say plasma light is safer because the potassium is only a normal. If the patient is not in hyperkalemia, you can safely give plasma light as a maintenance solution. Properly. We were previously thinking that we should avoid totally all sodium containing, I mean potassium containing solutions like inactive or other light. Now the recommendation is go for plasma light if the pre-operating potassium is normal.
Sir, in the practical exam, they frequently ask about parenteral nutrition fluids also, sir, or blood transfusion fluids and
see,
blood
per se, if you talk about IV fluids, it will be covering only the normal, commonly used IV fluids. But if you want to talk about special situations, then you have to talk about blood replacement as a blood component. That is a separate topic by itself. And normally they can't keep a blood bag in the examination and ask you to talk about, but they can diverge from the IV fluids. If the number of candidates are more for avoiding repetition, they can go for asking about blood, how do you separate the blood components, what indications for use in HPP, what is indication for use in rare precipitate. All the basic knowledge you should have. Similarly, enteral and parenteral preparations, they are not classified exactly under IV fluids. They come under more category of nutritional support, the ICA. So all the enteral, TP and parenteral nutrition preparations, they are all very highly osmolar. That's why the recommended route is central.
Parental nutrition will usually be in the OSCE. When they put the central line and other things, that's when you will get the parental nutrition and all that. Never comes under IV fluids.
The composition is mainly of the basic metabolic elements like those fat and proteins, depending upon the need of the patient. That comes under a special category. It doesn't come
yes, sir.
Regular IV fluids.
Sir, one more request, sir, from on behalf of students. I request Vasni Madam also. PG students want to have a mock test before their final practical exam, sir. Vasni Madam used to conduct in KMC for exam going students a real experience, show of experience, how to tackle the exam scenarios and situations.
Is it possible to do it?
Sir, pardon, sir.
Is it possible to do it online?
Yeah, it's not like a physical. It's not like a physical exam, no. So I don't.
So physically we can arrange in Perambur, sir, and we can transmit it online to other benefit of other students also, sir. We can record it. We can conduct it in a physical form in RH Perambur. And we can have a laptop to show and record it in WebEx simultaneously.
Have you come back from UK?
Yes, sir. I'm back, sir.
Oh, yeah.
Thank you, madam.
Then we can arrange it like that, will you?
Sir,
If you are back, then we can arrange for a live examination.
physical. Physical இருந்தாதான்
Yeah,
சார் நல்லா
physical.
இருக்கும். Otherwise,
Yes,
it's
yes.
Physical, yeah. That can be recorded as you say. We can
Yes, sir.
And that means you have to go like the exam pattern with a long case, short case.
Yes, sir.
That will like a whole day program then. We have to concise it into say maximum 1 to 2 hours. Yeah,
Yes, sir. We have 3 students going for exam this June, sir. Dr. Arun, Dr. Mubin, and Dr. Rajesh. They are ready with 1 long case and 1 short case.
No, we will give the case. No, when it comes to exam, if you're doing exam
Okay.
pattern,
Okay,
we will
okay.
give the case. They need not be
Okay.
ready with anything. They should be ready with everything.
Everything.
Okay.
Yeah.
Okay, madam. Okay.
Yeah.
So, Dr. Arun, Dr. Mubin, and Dr. Rajesh, are you there? Please unmute yourself.
Yes, sir. Yes, sir. Yes, sir.
So, madam saying that they will give the case and we should be ready for a practical exam mock test. Is it okay?
Yes, sir.
That will be a good experience, right? Fine.
When is the exam? When is your exam?
And they got the centers allotted?
No,
Exam
sir.
student? Not
No,
yet,
sir.
I think 14th is your exam, isn't it? 14th
Yeah,
June.
14, sir.
14 June.
So we can have the mock test before that. Madam,
Yeah,
can
we
we
can.
have it somewhere next Tuesday, madam?
Vanilla.
Next Tuesday, can we have in the morning session or evening session, madam?
I'm okay with anything because I don't think I have any work. I just have to check it out. If there is a case, it can பார்க்கணும் அவ்வளவுதான். அதை தவிர வேற ஒண்ணும் வேலை இல்ல.
Okay.
Yeah, no
Case I
problem.
will keep
I'm
ready,
okay with
madam.
it,
Here
sir.
in the hospital, whatever suggestions, cases you suggest, I can keep ready, or I can create a
case-
scenario also.
Case scenario create பண்ணிடலாம். Sir,
okay.
sir சொல்லிட்டு ஆமா. Sir, we can
Scenario,
create a case.
Okay.
ஆமா, scenario போதும்.
Okay. ASCII also, madam, should we keep ASCII also?
எல்லாமே பண்றது கஷ்டம் ஒரே நாள்ல.
ஆமா, ஒரு long case, short case
We'll just
scenario மட்டும் வச்சுக்கலாம், madam. Yeah.
ஆமா, we'll just do the cases. What do you say, sir?
ஆமாமா. Case discussion மாத்திரம் வச்சிருக்கேன்.
ஆமா, cases மாத்திரம் பண்ணி.
That exam மாதிரி whole day தான் போகணும்.
ஆமா. Whole day போயிடும் இல்லாட்டி. We'll just do cases.
Okay.
We can probably do
session
even 2
வச்சுக்கலாமா, sir?
cases. Yeah.
Next Tuesday afternoon session after 2 p.m. after lunch. 2 to 5. Sir.
Okay.
Yeah, that will be okay.
2 to 5, or can extend up to 6 also.
அதில் 3 கேண்டிடேட்னாக்க அதை பண்ணி ரெக்கார்ட் பண்ணி மற்றவங்களுக்கு you have to show.
Sir, your voice is breaking, sir.
No, if you are going to record that and show it to other students,
Yes, sir.
3 people, we can finish in 3 hours max.
Yes, sir. Okay.
It should be time specific. It should be time
Time
specific because that's how it's going to be in the exams.
ஆமா.
Okay.
So no
yes,
point
madam.
going on and on. Yeah.
So each candidate 1 hour கொடுக்கலாம்ல, madam?
Long case
Not-
எத்தனை டைம் இல்ல ஷார்ட் கேஸ் எத்தனை டைம் அந்த மாதிரி டிசைட் பண்ணலாம். Long case usually they give 20 minutes. Short case
Okay.
5 minutes தானே, 5 to 10 minutes.
Okay. So
So
30 minutes per candidate.
ஆமா. So 1.5 hours we will have to finish.
Okay, sir. Okay, sir. So we'll start by 2:30 and we'll try to finish by 5:30, sir. 2 hours.
Yeah,
total.
yeah. 4:30, yeah.
That should be good. Yeah, that should be.
2:30 to
4:30.
4:30. Okay, sir. 2:30 to 4:30.
Yeah, we'll finish the exams and then after
Yeah.
that we can probably give our opinion as to who spoke, how, things like that, how they can improve.
Yeah,
அதெல்லாம்
things,
சொல்லி-
yeah. Yes. Okay. Okay, madam. I'll arrange the logistics for next Tuesday, 2:30 to 4:30, exam for the students, and suggestions and discussions from 4:30 to 5:30.
Sure.
Okay, madam. Okay.
I think such a way that others can watch it while it is going on, if possible.
Yes, ma'am. Yes, sir. If physically somebody wants to watch it also, they can come and.
Yeah.
Can that be allowed, sir?
No, but
Yeah, why not?
students outside, like Pratik Shukla and those who are hill stations.
Yeah, they can be given online.
Online.
Physically,
Yeah,
yeah.
that can be-
Online, I can make it available, sir, for them. And physically also, if other students, if they want to just observe,
Those
they
who are
can also
inside
be.
the city, Balaji and other institutions, if they want to watch and come and watch, they can do that.
Okay, sir. Okay, sir. Okay. Sure, sir. Okay.
Right.
Thank you, sir.
And it's
Thank you
compulsory,
much.
and it's compulsory that the candidate who's presenting must have the video on. Make sure that he has nothing else around
No,
him.
no, he will be sitting in front of us, madam.
In
My
front of us,
laptop will
then
capture
okay.
both the examiner and the student.
All right, okay then no problem.
Yeah, one laptop is sufficient. We can focus in such a way that exam scenario is captured and that will be live available online.
Sure, okay.
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 Thank you, sir.
Thank you. Thank you,
Thank you,
ma'am.
sir.
Thank you, sir.
Thank you.
Thank you, dear students. It's a very exhaustive and wonderful session today, and I'll upload it in our website and YouTube channel for the benefit of those who could not attend it today live today. And by next Tuesday, we'll be, as sir and madam has kindly consented, and our students are ready. We'll have a mock test on next Tuesday, but the timings will be a little bit different between 2:30 p.m. and 5:30 p.m. And I hope all the students will make best use of the opportunity. Thank you once again, Professor Nagasamy sir and Professor Vasanthi madam and dear students. Shall I sign off this meeting, sir?
Yeah.
Thank you, sir. Thank you. Thank you, madam. Thank you, students.
Thank you, sir. Thank you, sir.
Thank you, sir.